married. So I went off to medical college, and in medical college you have the opportunity of visiting another country. So I visited Java in Indonesia, and I saw a very sad experience there. The doctor from Australia that had been working in Java for 20 years had married an Indonesian wife, had 2 Indonesian children that spoke Indonesian, English very poorly, was told to get out of the country because he was no longer wanted. They revoked his visa and sent him packing. And he was distraught because his life's work was over just as mine was beginning. And he thought it was very unfair, but I understood something very profound, and I could see what was happening, is that the old colonial days of white doctors going overseas and running health services for another country were coming to an end. And in this new era, what people were looking for were more partnerships and empowerment rather than dependency and colonialism. And I got it. I could see why the Indonesian government were doing this. So I went back home realizing that my future career was going to be more complicated than I thought. And thankfully, the first thing I did was to go out to Ethiopia to work in the famine in 1984. And I manned a refugee camp in Lalibela in northern Ethiopia. And again, thankfully, I was a very young doctor, so I hadn't yet had time to become arrogant like consultants and professors, thinking I knew everything. But also, thankfully, I was the only white person in the camp too. And I realized that the only way I could be effective in bringing down the dreadful death rate, we had 12 children every day dying when I first arrived in the middle of the famine. And at one point it went to 20 people a day dying when we had a cholera outbreak there. I realized I work as a team with the Ethiopian health workers. So I made good friends with them, and instead of me saying, this is what we're going to do, I changed it around and I started asking, how can I help you? And that experience was empowering for them because I was able to help them, and eventually we were able to bring the death rate down to 0 over a 6-week period. But it was very empowering for me because I began to understand the strength of partnership and teamwork. Well, following that, I went to work in Nepal, in Kathmandu, and I worked in a typical missionary situation. And I loved the country, I loved the people, I loved the mountains, but I didn't fit into the system because it was colonial. It was white people telling the Nepalese what they should do, paying them, and only giving them the wages if they did what the white people told them to do. We were the bosses. And they didn't even make friends with the Nepalese people. I was really hurt by that. Lots of the doctors there stayed in company with other British and American people. They didn't make friends with the Nepalese people, which I did, and my wife did, you know. And I felt I couldn't fit into that system. So we then went to work in Saudi Arabia in order to save money, so I could then follow my heart after the Second World War. And the idea was that you would twin your town in Britain with a town in France and a town in Germany, and the friendships that developed through the town twinning would then encourage people to stop their politicians from ever going to war with each other again. It was town twinning to stop war. But I realized by turning it on its head and doing something that, as far as I knew, was new and nobody else was doing, bring about the cohesion where the government and the non-government organizations work together for the good of the whole population in unity. And that integrated model of healthcare especially can be followed through the trail. That we were training primary healthcare workers through the NGOs. We were providing motorbike ambulance service through our own coalition against poverty that we created, and the government were providing the secondary healthcare services. So there would be a seamless transition from an NGO at village level to the motorbike ambulance service that we introduced, to the government hospital for the patient, and at no point would the patient have to pay for the service. It was integrated. And this was radical. And when we came here and started discussing this with the LC5 chairs and discussing it with the NGOs, they both said, nobody has ever asked us to work together before. This is unique, this is different. And I think that one of the most powerful things we've ever done is to establish that working relationship between NGOs and government and developing that coalition then. So that's how PONT began. The heart of everything we've done from the very beginning is because I have a passion for healthcare.
Absolutely.
A last bit of information. In my search for somewhere to do PONT, I travelled to many parts of Africa. I travelled to the Gambia, I travelled to Burkina Faso, to Niger, to Ethiopia, where I'd been in the famine. I travelled to Kenya, and I travelled to Tanzania. Over a 10-year period, I looked everywhere to find somewhere that felt right. And I was almost giving up hope I ever would find the right place. And I didn't even quite know why I didn't yet have the right place. But they told me that Soroti would be an ideal town to twin with. But while we were in Soroti, there was an attack by the LRA, and our team had to retreat to Mbale because we were in town when the attack happened. And I thought I'd never come back to Uganda again. But here in Mbale, I found the place I'd been looking for. It was remarkable because the people here are special. There's an affinity between Ugandans and Welsh people. My friend here is English, so I'm not going to say too many bad things about